I think the first thing I'd kind of like to mention is how I ended up here. So I'm on this thing called the LDA Legislative Affairs Board. And so we vote on things for dentists and making laws and all this stuff. It's typically very boring, dry stuff. And so we have a quarterly meeting and I go up to Baton Rouge and we all meet together. And 2 meetings ago, I think it was, Annette Drawdy, who's the kind of the person that runs this thing, goes, hey, we had these doctors and this guy, Chad, call in. They're talking about trying to get legislation passed where we can actually get, teeth pulled and treat cancer patients that are going to have chemo and perhaps have the medical insurance pay for it. I woke up. I just went, oh my God, this is great. We treat people all the time. That's one thing we kind of forget about, right? We need, prior to people getting treated for cancer issues, before going radiation therapy and chemotherapy and all this stuff, you got to make sure that their mouth is infection free, because we don't want this stuff popping up when they're halfway through treatment. And then how do we deal with it at that point? So one of the problems, though, is insurance. Patients just can't afford a lot of times to have this simple thing, really basically a simple thing taken care of prior to their treatment beginning. So we're working on legislation to make that happen. And so that's a big deal. It really is. And thank you for kind of putting me on the spot going, this is our most important piece of legislation this year. Dr. Boo, yeah. So it's huge. It's huge. And I hope we can get this thing to go through. The other thing is, I didn't have lunch today. I don't like to eat too much lunch. I'm a eat dinner, in the evening kind of guy. And Danielle made me really hungry, so I'm gonna try to make this short so I can get a nice, broccoli or something of that nature. And you'll also notice that my slides, they're kind of dry. I don't have any pictures or anything like that. Typically, my audience that I speak with are dentists, right? And when I get dentists in front of me, man, I got videos, I have 3D renderings of teeth, all this fun stuff. I'm not gonna bore you guys with that. I just wanna drive home the importance of oral health with the cancer patient, everyone. But a lot of times patients will just kind of put that off, neglect everything, right? Until it becomes such a priority that we have to deal with it immediately. So, and I'm going to flop around a little bit. I'll try to go through the slides, but for the most part, the take-home message with this is, once a patient's diagnosed and they're going to need treatment, get them to a dentist, right? And I'm going to say this as gently as I can. Try to make sure, if you can, to have the patient do a little research on the dentist that's doing their work. You want to get somebody that's going to be concerned about getting them healthy and getting them through this huge hurdle of treatment, as opposed to trying to make a few bucks off of it. I'm just being honest, right? My wife gives me a hard time all the time because I'm always pulling teeth for free, right? One day I'll end up living under the bridge with that guy that I wanted to give $2 to earlier. But anyway, let's move on here. So the title of my talk is Oral Health Management and Rehabilitation for Patients with Oral Cancer. This doesn't necessarily apply specifically to oral cancer, cancer in general, cancer that we're going to be treating through various methods, radiation therapy, chemotherapy, whatever method, surgical therapy. We need to go ahead and manage these patients before we start on those treatments, because we can have some problems. So our learning objectives are to recognize the oral complications of head and neck cancer therapy. The biggest thing that we see, and man, it's kind of horrible. Teeth are a big deal, right? You can't eat without your teeth, you can't smile. But in addition to that, oral mucositis, this stuff is just horrible. These patients aren't able to, it's the most miserable thing I've probably ever seen in my life, right? Then, in addition, we have the added fringe benefit as being dentists. You have uterine cancer, kidney cancer, brain cancer, all these things. We have the additional fact that a lot of times the patients, after we make them an obturator to kind of fill the hole in their jaw, they go, "Can you make it whiter?" So it's something that everybody sees. But we want to recognize the oral complications, understand the importance of pre-treatment dental clearance, making sure these infections are taken care of. And I'll tell you now, if a patient comes to me and a tooth looks at me crooked and they're about to go through radiation therapy, I'm getting that sucker out. I mean, I might have a filling that normally I'd go ahead and just say, fill the tooth, right? In this case, the biggest thing is just to make sure there are no complications during their treatment. And then I review some prevention strategies for radiation complications and understand prosthetic rehabilitation options. That's my favorite, right? I hate to see these people going through this stuff, and I want to do my best I can to get them better. So prosthetic rehabilitation options are, if there's an oral antral fistula, this big hole where they're eating and the food's going into their sinus cavity, I'm going to make them something where they can eat again. And that's a huge thing. And I'm a builder. I'm a builder by nature. And so why oral health matters, I'm just going to say, hey, Danielle told us all about that. I'm not going to go through it. We all know why oral health matters, right? Especially just in the regular population, but especially in patients that are undergoing some type of treatment. You guys know a lot more about this part than me, right? All the different modes of treatment. The big thing I see, our biggest thing, I really worry about radiation therapy in the head and neck region. We just see some stuff. A patient could be eating a Dorito and they show up at the office and they have a piece of bone sticking out where just this minor injury caused a serious problem in the area of radiation therapy. Let's see. Boom. And I'm moving a little fast because I know I have a few slides in here. I don't want to hold this up too much. So yeah, up to 90% of radiation patients develop oral complications. Probably everyone I've ever seen that had any kind of head and neck radiation, their salivary glands are shot. You're just seeing a lack of saliva. They're not actually able to produce saliva. So it's a rarity to see someone that isn't having some kind of issue with it. Oral complications can interrupt therapy, right? We don't want that occurring for sure, because if you can't treat them because of this oral infection, it was something we could have proactively treated. We definitely don't want to run into that. And then pain and infection, impaired nutrition, right? If they can't eat, they can't get the proper vitamins and all that fun stuff. Here's the other thing too. Who doesn't like to eat, right? You get a patient in that maybe hasn't had a meal. Where they're to the point, I have this one lady, they were getting ready to put her on a feeding tube, and I'm going, this is horrible, horrible, horrible. That was a couple of, late nights to midnight working to get her taken care of. And then early dental intervention improves outcome. If we can get to them early on, then maybe we can do something about it. So pre-treatment dental management. Recommend 2 to 3 weeks before radiation. We just want to get in there, get it taken care of. You guys are on a timeline. As soon as you decide that you're going to have this patient going through treatment, we're in a rush. We're going to get this stuff done. So a lot of times that's why we aren't doing root canals on maybe savable teeth. We might not know the potential outcome for a month or 6 weeks, because sometimes you'll do a root canal on the tooth and guess what? It didn't work and you got to pull the sucker. We don't play that game. We get them out in the way. Eliminate infection in unstable teeth. If I look in the patient's mouth, I think it's bad, it's coming out. Reduce osteoradionecrosis risk. You don't want to pull a tooth after they've had radiation therapy. You'll see some horrible things going on. And to educate the patients on oral hygiene. A lot of times these patients will be in a removable prosthetic, a denture, right? And they aren't cleaning that thing, and that food's getting stuck in there, and it's rubbing against the mucosa. And without undergoing any kind of therapy, it's kind of a horrible situation. You have to educate them. You have to get them cleaning that stuff. You have to get them cleaning their teeth. You need to monitor them. You need to have these patients come in every 3 to 4 months maximum, post-treatment, to make sure that things aren't getting out of control. Let's see, next one. So teeth often removed before radiation. Like I said, here's a list of things, but if it is suspect to me whatsoever, we're just going to extract it. And, I'm not saying I'm going to go pull a whole bunch of good teeth out of an individual, but we just don't want to take any chances that we don't need to take. One of the big things that we see is oral mucositis, right? So their salivary glands are kind of shot, right? Nothing's working right. And look, this stuff is so painful. I'm sure you guys see this quite a bit, right? And it's really hard to do anything that can alleviate their discomfort. I'll usually recommend, to start something simple. I'll do baking soda, salt, and water, have them rinse with that, see if that helps. If not, we'll put them on some magic mouthwash. It has a little bit of lidocaine and steroids and stuff, but it's still a rough road. the cleaner they keep their tissue, the better they take care of their oral cavity, the better their nutrition is, the less likely that you're going to see these things. You will need to we do need to manage them at some point, but see, I'm turning that into you need to manage it. No, it's my job. You know, it's just a huge thing. And the xerostomia, in general, in dentistry, problems with teeth come from problems with the salivary glands, right? Either they're not functioning properly, or the immunoglobulins being produced aren't in the right ratios, or you're not getting bacterial, destruction like we should. We're not keeping their immune system in check. And so once you destroy the salivary gland or make it not function as well as it should, you're gonna see these issues. So even in a healthy, non-treated individual, medications, Danielle mentioned medications, even blood pressure medication can affect the salivary glands. And once the saliva isn't being produced the way it should, oral hygiene becomes much more important, but it also becomes almost a losing battle a lot of times to be able to maintain their teeth. You think, oh, I'll go to the dentist, I'm gonna get a root canal, and we get a filling or whatever, and it's gonna be better. No. This is kind of like, we always call the lower first molar in an individual the money tooth, because we'll go in, we'll fill it, then we'll go back, we'll do a root canal on it, and we'll crown it, then we'll pull it, then we'll put an implant. And it's just this sequence of events. We do our best to maintain the dentition as long as possible, but anytime you start undergoing treatment for the dentition, you're kind of living on borrowed time, And so this is something we see radiation carries with radiation therapy. You'll start to see decay around the margins of the teeth. So the reason we want to have them come in often, every 3 to 4 months, is we want to be able to detect these lesions as early as possible. So what we do in a case like this, if we can catch it at this point, we have fluoride releasing materials that we can actually put in those decayed areas of the teeth and kind of try to maintain them and keep them from getting worse. And we may have to repeatedly, take these out, put them back in, but we have to maintain constant vigilance on these teeth in order to keep them as healthy as possible. Once we're down to that level on that picture on the left, we're really having some trouble. If that patient underwent radiation therapy and the teeth have gotten to that point, what are we going to do? We're going to pull them. Sometimes we'll take an individual that's in rough shape like that. We'll do root canals on all of the teeth. We won't restore them. We won't put crowns on them. We just get the nerves out of the teeth and try to hold on to them as long as possible so we don't have to do the extractions on them. And so frequent dental monitoring, very important. If we see in patients treatment over 60 degrees, hypovascularity occurs. When the blood supply isn't getting to the bone well enough, any little injury that causes a disturbance in that bone can really cause some serious issues with osteoradionecrosis. And, I've had a couple of patients come in where, by the time they finish cleaning this bone out, the surgeon will go in and debride these areas. I mean, you lose the teeth, you lose, 25% of the jaw on that side. We're looking at making some kind of dental prosthetic. It becomes kind of difficult, right? So minor trauma can cause some bone necrosis. It can be very, very difficult to treat. So we also have functional impacts after oral cancer surgery. So we will find a patient's speech even is affected. If you have a communication between the sinus cavity and the oral cavity, and I'm gonna kind of give you an example. It kind of sounds very nasally, where you really can't even understand what the patient is saying. So we need to close that hole up so that their speech. And it blew me away. The first one of these cases I worked on, I was like, wow, it's so bad. The mouth and the nose, the vocals, very much like a musical instrument. Like when you go, oh man, if this thing isn't just right, it doesn't work properly. So you have to have some mechanism to go ahead and correct that speech impairment. Mastication difficulties, you can't eat if you can't chew, right? I've seen some people without teeth eat some insane things and they got by, but not recommended. Swallowing impairment, the food will go into the nasal cavity, patient just can't eat. And loss of facial support, you're going through cancer, you're going through this most horrible thing in the world. Now you're cosmetically things are going wrong. So that's a component of it. It's, keeping them healthy and everything, but we also want to try and make them as happy as we can as well, do what we can. Obturator, so this is an example. This is a patient. This is Miss Hazel. I saw her yesterday. In fact, she came in for a little adjustment. I didn't know she was coming in. I was like, oh, hey, Miss Hazel, She came in, she could not eat, it was rough. And so we probably made her about 6 different devices before we found just that perfect combination of things. And so my lab technician called her a couple days ago, and she said she had something going on, a little sore spot. He took a drill bit and cleaned it up. She's doing fantastic. She's gained weight, she's doing good. She's eating, she's happy. Her speech is fantastic. I can understand everything she says. And so that little picture on the left is we computer designed these things today. It's so cool, like with her. So look at this defect, right? See that big old hole? Try to take a dental impression of that. Anybody ever had a dental impression taken for a crown or something, right? You can stick that way in that hole, and that's how it used to be done. What I did with her was I took a cone beam CT scan of her. I created an STL model of her soft tissue from that scan. Then I digitally built that device on top of that scan. Then I took this thing and I milled it out of a material called Duraflex, which is a flexible material. Then we relined it in the cavity to seal it up. And yeah, she can eat now. That's hard to fix because all that back area, kind of by where those bottom teeth are, that's flexible. Every time she swallows, this stuff's moving. And so we had to go through different materials and stuff. It made me very happy to see Miss Hazel yesterday. And you know how much we charged her? Nothing. I'm not going to send her out with that. I can't do that, But it'd be nice, and not just for my office. Isn't the whole, it's so other dentists start treating these patients. It's a big deal. And a lot of people that's going to do it for free, I'll tell you that. So implant-supported rehabilitation, not always an option in these cases, but Miss Hazel, for example, I wish I could go back in time. And so she had radiation therapy and surgical resection of her cancerous area. If I could go back in time, in that time period before radiation therapy and surgery was performed, if I go back in time and stick one implant in her, one dental implant, and then start treatment a few weeks later, then I actually have something I can snap the prosthesis on night and day, right? So when I say try to get them or help them research, maybe I could even make a list for you guys or something, dentists in the area that are going to think outside of the box like that. The surgeon I work with and we were just talking about this with another patient the other day. I think we're going to go ahead and do it maybe next week, get the implant in before everything happens, and then we're going to make their life a lot better just by being proactive about it. But so implants, we take these teeth now, we screw them in, all kinds of fun stuff. And a healthy person, yeah, we can do a lot. And a patient that's getting treated, it's difficult. And then long-term care, like I said, we want to see them every 3 to 4 months. Daily fluoride therapy, we'll make them some fluoride trays if they still have teeth that they can put some fluoride gel in and cover their teeth to try and minimize the occurrence of caries. Monitor for complications. We just got to keep looking at, especially a patient that's wearing a removable prosthetic. That the tissue will change over time. And so with that removable prosthetic, it's almost like taking a pair of Dutch wooden shoes that you're wearing, and we're just sitting here trying to keep those shoes comfortable for that patient. So you have to get them in. A lot of patients, you'll give them a denture, you'll never see them again. These patients, you got to come back. You can't just go, yeah, it's a little sore. No, tell us, get you in. So we got to monitor them for complications, and then maintain prosthetic restorations. We got to take care of their teeth and their dentures. So this is just a list of who's involved with this stuff. Kind of the way I work the system at my office, which hopefully this is all a learning process to some degree. The reason we started seeing a lot of these patients is because, like I said, I'm a builder, right? I'll build anything. And so the surgeons in Homa got wind of that I build stuff, and we have a dental lab. And so they just started sending patients over to us to correct things, right? So we typically work, if I have a case, suspected oral cancer, we'll send it to the surgeon, or another dentist, they'll send it to the surgeon. So we really don't have any interaction with the oncologist. The oral surgeon interacts with you guys more than we do. But, you know, at some point, I would like to be able to maybe get, you know, a little bit more education and learning and, you know, building a better network so that maybe we can work with people, nutritionists, right? In fact, I need to talk to you about a diet for people that their implants get rejected. Thank you. And then speech therapy and nutrition, we do have a speech therapist available. We don't use her too much. We can usually, if we do the prosthetic right, and get the form of this thing right, we could usually get their speech in-house much better. But yeah, it's a team effort, just like you guys, you know. And key takeaways: oral complications preventable. We just got to make sure we're looking out for them. Pre-treatment dental clearance is critical. Make sure you get that done. Don't forget that, right? Of course you won't, right? But still. And then, you know, collaboration between you guys and us. And the rehabilitation restores function and quality of life. And I'm just waiting for Miss Hazel with her little prosthetic device that I built her to tell me that she wants her teeth whiter or something. And so this is my final slide. So I'm sitting in my office. I work a lot. It's okay. It's okay. And I'll leave you with this little story. When I was a kid, and I've done a bunch of stuff, you know, did engineering at one point. I used to work on cat brains. I was a researcher at Tulane for a while. I've done a lot of stuff. But it was one Sunday, and it was nice, a couple years ago, right? Really nice day outside, and I'm in my lab. I'm working, building some teeth, you know. And I'm just, man, I want to be outside so bad. I just want to go fishing, whatever, right? And then I'm sitting there, and I have in fact, I think all three of them were going 3D printers, 4 of them, whatever, right, making noise. I hear my milling machine in the back. I have my CAD software up on my computer, and I think back to when I was a little kid that I liked chemistry and I liked science. And I go, man, quit whining, right? You're doing exactly what you wanted to do. Shut up and get to work. And ever since that day, I went, I got this, and I do it. I enjoy it. It took that moment of clarity to go, nah, this is fantastic. And if we can help people doing it, and I'm not just talking about the routine stuff, the cosmetic dentistry. I let somebody else do the veneers. That's not, I do them if they beg, you know, and I say, I don't want it. But the thing is, we do a great job too, because we have our own lab. But so this is probably around midnight one night, right? And I just had this model. I was painting the little gums on it, screw-in teeth. And it was laying on my desk. And then there was a copy of the law we were talking about, the draft of the law. And then back here, see that little thing? It says Auctioneer Health back there. That's something to do with this convention. This is midnight one night. I laid this thing down and I looked at it. I said, take a picture of that. Take a picture of that. That's kind of that's what we do at my office. And we would hope that you can find dentists that will do the same thing and be into it as much as we are and get your patients taken well care of. All right? And I think I'm going to let you guys take a nap now, if you haven't already. Thank you.